Bismillahirrahmanirrahim. Today we will have case quiz number 61. Case data: 41 years old male working as farmer with a history of chronic hepatitis B infection treated with entecavir, and the patient was also diagnosed as having radiographic axial SpA, which is formerly known as ankylosing spondylitis, which is treated since the last year with weekly Etanercept injections. The patient was presented with prolonged fever and malaise for 2 weeks. The patient complaining also of chills and night sweats. But the patient denied having coughs, myalgia, bowel movement abnormalities, headaches, or any burning sensation during urination. On examination, the patient has high-grade fever, 39 degrees centigrade, a 1 centimeter large, not painful cervical lymph node, stooped over posture and totally rigid spine, blood pressure within normal 120 over 60 millimeter mercury. Cardiovascular examination is normal with no murmurs. Investigations showed normal CBC, shooting CRB of 244 milligram per liter, elevated ESR of 37 millimeter per 1 hour. So elevated ESR but shooting CRB with inflammatory pattern on serum protein electrophoresis. Slightly elevated liver enzymes, as the AST was 46 and the ALT was 36, while other liver and renal functions were normal. Blood cultures were negative and serological tests for Epstein-Barr virus, cytomegalovirus, Brucella, HSV, HIV, and HCV, all of this were negative. Transthoracic cardiac ultrasound showed no signs of endocarditis. ANA by IF was borderline positive at only 1 over 80. ANA profile was negative. C3 and C4 were normal. Testing for hepatitis B surface antigens and antibody to hepatitis B core antigens HBsAg and anti-HBc were positive, but PCR test for hepatitis B DNA showed low viral load. CT scan of the neck, chest, and abdomen showed a lymph node of the fourth cervical chain, but no abscesses or internal lymphadenopathy. PCR for Clostridia burnetii DNA was not performed. By the end of investigation, serological diagnosis of unknown disease appeared to be positive for both IgG and IgM. This is the question: which is this possible disease? Therapeutic history: the patient received doxycycline 200 mg per day with temporary stoppage of Etanercept for 2 weeks with marked improvement of the case. So, what is the most probable hidden infection in this case? The answer is yes, Q fever. Q fever. Regarding the fate of this real case report patient, this is a real case report, not just an arbitrary or imaginary case. By the end of investigation, serological diagnosis of Q fever appeared to be positive for both IgG and IgM. The patient's physical condition improved as the fever stopped, and he was checked on regularly period for signs of progression of chronic Q fever. Liver enzymes was progressively back to normal, as well as CRP levels that were negative during his last medical visit. So, what is Q fever? Q fever is a chronic zoonotic rickettsiosis caused by infection with Clostridia borniti. It's spread by aerosol transmission from contaminated soil or manipulation of infected livestock and its product. Other rare forms of transmission have been described, such as oral consumption of raw milk, sexual transmission, and tick bites. It can present as either acute or chronic disease. Individuals at risk of Q fever are usually males of age equal or more than 40 years old, particularly if they are farmers, veterinarians, slaughterhouse workers, and laboratory workers due to exposure to animal products. Some conditions such as immunosuppressive therapy, pre-existing valvuloplasty, or vascular graft may expose to a risk of chronic Q fever infection. Acute Q fever manifests as a febrile disease with non-specific symptoms including headaches, myalgia, chills, and night sweats. However, up to 50% of patients with acute fever are asymptomatic. Other manifestations may include pneumonia and hepatitis, and less frequently meningitis, encephalitis, pericarditis, myocarditis, and cholecystitis. The diagnosis of Q fever is based on serological tests. IgM antibodies against phase 2 antigen are the marker of acute infection, while high levels against phase 1 antigen indicate a chronic infection. There is no consensus about serologic follow-up of acute infection, but serological control after 6 or 9 months of the acute infection in people at high risk of chronic infection is highly recommended. TNF-alpha has a major role in the defense against intracellular germs such as Clostridium borneti, as it has been proven that in mice. So TNF-alpha suppression is responsible for severe heart lesions and early bacteremia of these infections. The literature regarding Q fever and the biologics in spondyloarthropathy is very rare, scarce. One case of acute Q fever in ankylosing spondylitis patient treated with infliximab has been reported, as well as a case of skin psoriasis under Etanercept manifesting with chronic Q fever. As for rheumatoid arthritis, 2 cases of chronic Q fever manifested as endocarditis have been reported in the literature in 2 women under Etanercept and were known to have had previous cardiac valve abnormalities. So the cases of Q fever due to or associated with biological treatment are until now very few recorded cases all over the world. A study during the outbreak of Q fever between 2007 and 2010 in Netherlands comparing rheumatoid arthritis patients treated with TNF-alpha blockers and group with anti-TNF-alpha naive individuals of rheumatoid arthritis showed a similar prevalence among both groups for Clostridium borneti infection, but with an increased frequency of chronic Q fever in anti-TNF-alpha treated patients. These findings, although statistically insignificant, can be a proof for the insufficient control of Clostridium borneti infection under the anti-TNF-alpha blockers. For our patient, being treated with Etanercept for a year could be an additional risk factor for developing Q fever other than his profession as a farmer. Another mechanism could be the interferon gamma depletion due to chronic hepatitis B infection. The role of interferon gamma in macrophage activation has been established against intracellular microorganisms such as Clostridium borneti, as it promotes its killing in monocytes through the apoptotic mechanism mediated by TNF. The treatment of Q fever is based on doxycycline and in combination with hydroxychloroquine in its chronic form. The duration of treatment depends on the presentation of the infection in its acute or chronic form. Our patient was closely monitored for appearing signs of endocarditis and he was administered doxycycline 200 mg per day for only 14 days. This case raised questions to the exact prevalence of Q fever infection among patients under TNF alpha inhibitors and especially to those with ankylosing spondylitis and the comparison of Q fever infection risk among different TNF alpha blocking agents depending on their mechanism of action, either monoclonal antibodies or circulating receptor fusion proteins. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 62. Wassalamu alaikum wa rahmatullahi wa barakatuh.